Good afternoon, everybody. Thanks for coming and joining us here at the Intelligent Health Pavilion. I'm Matt Muller. I'm a practicing emergency medicine physician in Dallas. I also work as a safety and quality officer for our group. So Emergency Medicine Consultants is a group that's mainly in the DFW Metroplex. We have about 300 physicians, about 150 mid-level providers. I personally work in a level 1 trauma center. We have a disproportionate number of unfunded and Medicaid patients, so that's a little bit of my bias, but we in Dallas have ERs of all shapes and sizes, so we sort of run the spectrum. It'll probably be no news to this group that patients continue to vote with their feet. As far as the ER, there's been a lot of gnashing of teeth about utilization of ERs for care. That's in a lot of cases not the patient's fault. We've created a lot of bottlenecks in the system, and so a lot of people come to us for the accessibility, for the 24/7 services, and quite frankly for the comprehensive nature of the care. So we have a big chunk of the acute care. The ER has a big chunk of the acute care slice in the U.S. right now, and take a big share in taking care of the uninsured sort of across the spectrum. However, all is not great when you do your acute episodic or your unscheduled acute care in an ER. And I'm sure this crowd knows that we're challenged with being part of a sort of a larger fragmented system. So if you have a chronic medical condition and come to the ER, a third of the patients in the U.S. don't get any sort of follow-up visits following those ER visits. If you come to an ER, you have an 8% chance of coming back within 72 hours. And a third of those patients will leak out of your system and go to a different ER. There's often a sort of emotional component to that. They feel like you didn't get it right, and they're upset, and they go somewhere else. And so they're looking for sort of another shot. It quite frankly probably is more about embryonic disease and the early state of the fact that people need to come back, and not so much that you missed necessarily, but the human element of that is that they feel like you didn't find it. So the ER is unfortunately characterized a little bit by lack of reliability for care transition. It can be fragmented, and often from a patient perspective it leads to unmet expectations. I see a lot of heads nodding, so I think I'm talking to an ER crowd. So as a safety and quality officer, what I feel and hear and think about a lot is that represents risk, and it represents risk from a safety perspective, it represents risk from quality, and particularly from the service satisfaction component. So we started thinking through that about a year and a half ago or a year ago, and thought a little out of the box, I guess, for ER, although a lot of folks are starting to head this way, and what if we could change the fundamental way we think about ER visits, and so that really we're no longer thinking about that 3 hours, 6 hours, or 10 hours in some of my EDs that the patient spends with us, but really, can we be part of the illness episode? And can we develop relationships over the course of a week or so where we're sort of there for the patients and continue to be there for the patients? And that what drove us to that point is thinking about safety and thinking about quality and value, bringing value to both the patients and value to the healthcare systems that we associate with. And so we started to explore this with Dr. McKinney and the folks at SiriusMD, and thought about really how would we take something that they're already doing and apply it to the sort of dynamic, on-the-fly nature of emergency medicine, and they've been great partners in that. I don't work for Sirius, but I'm a user of theirs and a big believer in the team that they've pulled together. And so this is what we're talking about. We're talking about 24/7 direct access back to the emergency medicine group that you saw in the ER. And you know, this is really no additional charge. It's on the fly. We register patients as we see them in the ER. We use a text-first workflow. I'll be a big proponent and tell you this is what patients want. It's a HIPAA-compliant platform, and this allows folks to sort of reach back and re-engage with us. And this is the healthcare that most physicians practice with their family members, with their friends, their neighbors. It's the back and forth over time that allows you to engage and then re-engage. This is not the call up a virtual care visit, get 7 minutes, pay a fee, and then you're done. This is an interaction over the course as long as it takes you to get your issues resolved. And that's really what we're talking about and what we've developed. So do patients like that? Sure. Sure they do. So the testimonials are anecdotal, but they're powerful, and so we've started surveying, and we rolled this out. We rolled this out in October of last year, and we are now surveying patients and starting to get some feedback from them, and the testimonials and the things that they're writing to us in our hospitals are really fairly motivating. And so here's a couple of those, and you see the words care in here a lot. So it's that people care about me and they're listening now, and that's really what's kind of motivating us, and quite frankly is working on the physician engagement side with our physicians. That's probably too small to see up there. It just shows that we're getting kind of all the age groups. So those bar graphs over there, age ranges, time of day, people use it 24/7. About 10 to 15% of it is the overnight folks, but we are getting all ages kind of throughout the day. The only data up there that I'm terribly interested in and somewhat proud of is the physician response time. So our median physician response time is less than 3 minutes. So a patient texts into us, we get back to them within 3 minutes. And then the duration of encounters is a real differentiator. So the median duration of our encounter is about 45 minutes. And so that's not 45 minutes of a dedicated physician time. We're interacting with multiple people when they're on the platform. But from a patient's perspective, it's the conversation at the pace that they need it. So if it's a mom and she's got a baby and she's taking care of the dog and she's running around the house, she can ask her a question, we respond, she gets back to us when she needs to. So it's what we do every day. This is not rocket science, it's the texting. It's the non-disruptive, passive, asynchronous communication we all do, and that's how we interact with the patients. Now the platform has full capability to go audio, video, but quite frankly, we don't need to do that. And most of the time when you offer that, patients don't want it. Their hair is a mess and they're in their house and they just want to get their questions answered for the most part. We, the physicians, feel like we occasionally need to talk to them. Less frequently do you need to see them, but most of the time it's just conversation. We go to audio or video less than 1% of the time. And we can do that at any time, but generally we don't find that it's necessary, and it's rare, if ever, that the patients want to do that. So this is about 1,000. I think we're at 12 to 1,300 encounters now. We've had kind of a deliberate slow rollout. So we started in 1 ED in October. We're now in about 15 EDs in our systems, and are going to go ahead and continue to roll that out over the course of the next year. We see about 1 million patients a year, and that will be our plan, is to give it to all 1 million patients. This is what the outcomes look like, if you may. About 85% of this stuff we just take care of. It's just resolved there virtually in the platform. It's a lot of reassurance. There are this label, we go back to the ER. When we send back people to the ER, we're doing that with physician to physician handoff. Those folks are usually coming back to the same ER they were seen the first time. We encourage that. So if I'm on the platform, I'll call the physician, tell them what's going on, let them know. We usually work them around the waiting room. It's sort of a physician referral at that point. So that's how we bring them back. About half of those referrals back in happen in the deep night. People wake up at 3 o'clock at night and they're having chest pain again. It's a little hard to sort of talk them through. You'll be fine. So those people tend to come back. Those of us that work on this thing during the day have a sort of much lower return rate. So my personal return rate, and I think I've seen 500 patients or so, 450 patients now through this, is about 7%, 6 to 7%. I actually send back in. But I will tell you, as an ER guy, those are the safety stories. So those are the viral infections that became meningitis. Those are the vomiting that became a bowel obstruction. It's the cellulitis that now needs to go to the OR. And so this is really powerful, and this is the part that's helping with our physicians getting excited and motivated about this, because when you go back to them and you say, Mrs. Smith, who you sent home on she got sicker, but she reached out. We brought her back in, got her into the hospital. It's a real driver for both service satisfaction from the patient side, but engagement from the physicians. And so I never, ever play these as, those returns as somehow a failure to the system. This is why we're doing it. We want to be involved with those patients. And so I mentioned we've started a survey, so patients are largely happy, it looks like. Are we improving their experience with the healthcare system? Yes, that's slightly worse there. Those are unmet expectations, and there's always unmet expectations. So sometimes that's that the technology didn't quite figure out. Sometimes it is very often somebody that went for a particular medication class they really wanted in the ER. They didn't get it for probably the right reasons, and they come here and expect to get it again. I tell our docs, we never do conflict management in text. email is a terrible way to fight fights, and so those are where we go to video, we go to audio very quickly and sort of explain the purpose of the platform. And the vast majority of those don't end up with a dissatisfied patient. They generally understand. This is an interesting slide, and one that I'm excited about getting more data on looking at. So this is what else were you going to do if you didn't have this program, if you weren't able to reach back out. And so that big blue slice is I was going back to the ER. The next one around in the top right, I was going back to a different ER. So we're not quite at a third like the very large study that I showed earlier was, but still a vast majority of these people were coming back to the ER. And we are, looks like, interacting with most of those folks. And a lot of this is just reassurance. It really is just reassurance. A little bit of additional symptom management, but mostly reassurance. So again, patients feel good about this. We feel good about it. We enjoy the interactions, and it's just been a real win for us as a group. And there's a lot of infectiousness now with the physicians getting excited about it. We're at HIMSS, so I'm going to close with just this thought, and then I'm going to take some questions because I'm sure you have some specifics on how we staff the service. But if I'm a patient, why do I want to download a health app? What is there for me? And there's a lot of, and you can put patient portal there. There's a lot of patient portals. There's a lot of apps that just really don't do much for the patient as far as delivering care. And so I'm a big believer in, we need to build this thing around sort of what the patients want. And if you're thinking about how redoing your flows and your workflows, man, let's talk to the patients and design for them. And so I would say, if you're building a health system app or a patient portal, if it doesn't deliver care where and when the patients want, you're probably not going to see a lot of traction. And I'm a kind of a little bit of a softy relationship guy. This is sort of why I work where I work, and so I think the same thing. If you're not strengthening relationships and if you're not building trust, really, what are you doing when you're building your apps? So that's a little bit about safe transitions.